B, Community Mental Health Funding Update. Director Kinch. Good afternoon.
Good afternoon, Mr. Chairman and Board. Thank you again for my opportunity to give you an update on community mental health. And as I get familiar with your system here. This is the update as I have today. My numbers are moving readily for each month that we do our reporting in the department. I want to introduce Cynthia Mack. Cynthia is the Chief Financial Officer for Macomb County Community Mental Health for last year, doing an outstanding job for us. She's here to support me if any difficult questions come up.
Sorry to interrupt, we just have to hit F5.
Okay. And so she'll certainly be able to help me out if anything comes up. Always wanted to start with our missions and value statements. Some of these things you've seen before, but it's good orientation, good recognition for the board to see it again. You know, guided by the values of our consumers, we try to support our consumers with community participation, self-sufficiency, and independence. So when we look at all of the activities of our consumers, we certainly want them to be as independent as we possibly can make them. As you know, we are a unique bird in our own right. Community mental health in Macomb County, we're a community mental health services program that actually delivers the services. We have 510 employees that actually deliver services to our network, and I'm going to talk about the finances about that in a minute. We're also a prepaid inpatient health plan, so we're a managed care organization, and we have the financing to support not only our direct operated staff, but also all of our contractors as well, the Henry Ford Health Systems, the St. John Health Systems, and the like. And again, we are servicing those consumers with the most serious of conditions, most serious affective disorders and thought disorders. Generally speaking, our consumers are with us for quite a while, and it's not as though they're here for 6 months and they're gone. They may stick with us for many, many years. We also serve the mild to moderate population, those consumers in our My Health Link demonstration, and those folks have a little lesser of a psychopathology going on, but that's the network of folks that we do serve. We have an extensive website, and I would encourage you at any point in time, if you want to learn more about Macomb County Community Mental Health, certainly go to that website. And as I indicated, there are 10 PIHPs in the state of Michigan. Those 10 PIHPs support financially the 46 community mental health services programs. They also support hundreds and hundreds of providers throughout the state that also contract for services. They are the managed care organization. As in Macomb County, we're a standalone, I've said this before, a CMH SP and a PIHP. That map you've seen again before, it's very telling. We are not Lapeer County, we are not St. Clair County. Macomb County, Oakland, and Wayne are very unique in right to relative to the services that they provide and the management of the system of care. And particularly Macomb. Nobody else does what Macomb County out of all 83 counties in the state of Michigan. So that map, I always use that. It's kind of telling where things are at. We talk about Medicaid rates and Medicaid rate setting, Medicaid rebates. Just a quick overview. Medicaid rates are drawn from the state through an actuarial analysis every 2 years. State of Michigan has to do an actuarial analysis. They're certified. The rates are certified by the federal government as being actuarially sound. They're not up for debate. We do participate in the rate setting process. One of my administrators, probably Cindy, sits in on the rate setting process. That allows us, once the rates are determined through all the PIHPs, the 10 PIHPs, that allows us to draw down those Medicaid rates with state dollars to be in the federal financial participation. And once they're approved, they're final. There's no other debate with that. So as you've heard me and other CMH board members and yourselves and legislatures talk about the unfairness, what it perceives to be the unfairness of Macomb County CMH and our rate reduction, CMS said the rates are fair. So live with it. They're not debatable. And I'll get into that a little bit further as well. And just a quick overview. Back in early 2000, the PIHP, they were funded entirely on their spending patterns. So you think back 17 years ago, if you spent $200 million worth of services, you received $200 million worth of funds. And so as the other counties started to draw more and more attention to thinking that the metro region really has the majority of the money, which they do because they have the majority of the consumers, they also are looking for politically and through righteousness of their own to have more state averaging so that they get more of the monies to treat their population as well. So this rebase that's been going on has been going on for a while. They started looking at comorbidity factors, and they have numerous comorbidity factors. I just threw a few of them down here just to get you a general idea of what comorbidity factors were related to historical and future spending habits. In 2010, under a capitated model here, it was 2/3 spending, 1/3 comorbidity factors that were rolled in. In 2011, they went to a 50-50 distribution, 50% comorbidity factors, added factors, and 50% funding. And then in 2014 is where the rub comes in. In 2014, it was an entirely comorbidity and other related geographic factors, prevalence factors, treatment unit factors that resulted in our financial situation that we're in. So prior utilization of services is no longer a predictor of future utilization of services. So that just took effect in 2014 and is playing itself out right now. So when we talk about movement to statewide averaging, there's Medicaid rate setting is synonymous with Medicaid rebase, which is synonymous with Medicaid redistribution. You hear all of those terms. They're all one and the same, and I think that's important to notice here. In the 2017, 16, and 17 budgets, when they removed the utilization factor, it affected Macomb County more than any other community mental health services or PIHP out there alone. Some of the other programs were affected minimally. We were affected by the amount of 17% reduction. So what did that happen? What happened to Macomb County? Severe reductions in Medicaid funding. It really required detailed person-centered planning. You should have that all along, but it really requires detailed person-centered planning to make sure the supports coordinators, the case managers actually have everything that they need in that consumer's plan right down to the detail. If not, it's not going to get approved. Aggressive utilization management practices. I italicize that because that's the best word I can think of. I think of all types of different words I could use to really describe how we do utilization management, but I have to tell you it is the most aggressive form of detail that we're attending to these person-centered plans or the service isn't going to be authorized. The largest reduction is in community living supports. We've affected probably the lives of 2,000 or 2,200 people in some way or another, either lesser or more amounts of CLS reduction, community living support. It's been a negative impact on our families, our consumers. You see them on the news, you hear them on the radio, they're contacting our legislature. It is what it is. We have to correct for that imbalance of that $33 million reduction. It's affecting our partnerships with our valued service providers, and I'll explain more about that later on. I mean, as far as what we can offer up them in the way of competitive rates. Challenges to be able to offer competitive wage, particularly for your direct care workforce. I've talked to you about the direct care workforce crisis that's here in Macomb. It's in the state, and it's going on throughout the country. There are not enough direct care workers in all of our service populations to be able to take care of our needy people. It's an imposed hardship that's just a repetitive hardship on families and those supporting their families, members, and trying to cope. And it's compromising our services. This one I'm going to have to scoot down here so I can see it. Does it show on your screen?
Yes, it does.
Okay. So this is, and I apologize for this, it was kind of a cut and paste. So this is where our spending goes. And so if you look at residential treatment, that first number, I think it looks like $64 million. $64 million worth of services goes to residential treatment. We have 120 group homes, and those consumers are receiving care 24/7, 365. You look at the other, these are just, it's kind of an executive brief of a utilization analysis, and for your purposes, that shows the largest funding sources that are in there. Our total contracted amount in our network, I think that's 158 million, if I'm seeing that correctly.
Mm-hmm.
So that's, again, all of the group homes, all the CLS providers inpatient, outpatient providers, skill building, OTPT, speech language, all of that's contracted out. The direct network, that $29 million, that's the staff that are employed and the contractors, the professional supports contractors that are employed by community mental health. That's the CMHSP side, $29 million of direct operated services. Most of those folks are county employees. And there's around 510, about 350 of them are county employees. So my administrative costs and board costs are about $14 million. It's a little high for me right now. I won't go into it, but I'll be more than happy to entertain a discussion at some point in time why the PIHP has ongoing administrative challenges and requirement by the Department of Health and Human Services relative to the management of the PIHP operation. There are more and more functions that they're delegating and passing downstream to us, non-paid, and they expect us, and we have been picking it up under administrative costs. The board, the CMH board, likes to see that administrative cost closer to 5 or 6%, and it hasn't been at 5% in a long time. And I think that number is around 7.6% admin cost right now, a little bit higher than I want it to be. So the total, I think the bottom line, I think that says $210 million. So that's kind of where our monies are going. The bad news, there's good news coming up here real quick. The bad news is when we closed out last fiscal year on October 1st, on September 30th, we were projecting, and I'll walk you through this real quick. It's a pretty easy read. If you look at the center column there in 15-16, our actual revenue in 15-16 was $185 million. I'm just talking straight Medicaid. I'm not, and I'll talk about that more so too, not to confuse the issue. Straight Medicaid, $185 million. When we finished up on September 30th of last year, when we closed that fiscal year, we had $15 million in fund equity in our internal services fund. So we carry that $15 million over into 16-17, so that's revenue in the bank. And it's part of our risk-based contract, the money has to be there. Then you can see the next yellow box there, our actual, or not our actual, but our projected revenue for this year is $152 million, just in the Medicaid side. Now, there's a lot of moving variables here. If there's increased enrollment, we get more money. If the enrollment goes down, we get less money. The rates are changing, the per member per month rates are changing. But you can see as a quick read there's $33 million differential what we received last year than this year. So by the time we look at our expenses of $24 million, we were looking at a deficit of $10 million. We burned through everything that we have, and we were going to spend our 7.5% on our risk and go into the state's risk corridor. We can't come out any lower than being zero. And we were going to be into the state's risk corridor to the tune of $9.8 million. That's what we started October 1st, if we did nothing, if we stood flat-footed. We didn't stand flat-footed. So here's where we are now through mid-year. So this report was just drawn up. There's a revised picture of this that's making it even look better yet. But the revenues stayed the same. But the expenses dropped by about $10 million. And so before, in the previous slide, that revenue to expense projection was a negative $24 million. Now it's at a negative $14 million. So where we're at right now, mid-year through this year, is that we actually have $80,000 in the bank. So we corrected for that $10 million in the first 6 months. And how do we correct for it? It's primarily on the backs of the consumers, but I'll explain that in a few minutes too. Not all on the backs of consumers, but the reduction of their CLS services, the aggressive utilization management of their CLS services. So this is good news. It's good news from a financial perspective. Yeah. As a CEO, I sit here and I'm, very unsettled with what we have been doing in creating hardship to our families. I get that. It's not what we're here about, is to create hardship. They already have it hard enough. This is Healthy Michigan. So there was Medicaid. This is the Healthy Michigan piece. So we're showing there was a little bit of a reduction, maybe an increase I can't see, but we have about $1.1 million in Healthy Michigan, which is the Medicaid expansion. This is both of them combined. So this is what you're looking at here at mid-year status. If you combine the Medicaid and the Healthy Michigan, our fund equity is about
27.
$1.2 million. We have to get up to 13. This is general fund. There's the good and the bad. I'll tell you what. When you see me like you fixed one problem, another one pops up. Not too many years ago, we had $26 million in general fund dollars. And then when Healthy Michigan came around, they brought that number down to $14 million, then revenue $9 million, and now it's $8.5 million. A few years ago, not to my liking, we ended up lapsing money back to the county. We lapsed money back to the state of Michigan. That was a bad day. Last year, we carried forward the $890,000, and right now I'm projecting a $3 million deficit in general fund. And that's going to come down. We're correcting for that as well, too. This is mid-year status report. That is related primarily to our efforts to grow roots under our urgent care behavioral health clinic. We have an urgent care center that's open 24/7, 365. We talked about that before. I think it still has the opportunity to be a great community model, state model. There are others that are out there. I think it is going to be important to our future to have that, just to be able to get it to grow roots and not have me charge a lot of it to the GF is a problem for me. So I have to fix that, and I'll bring that number down, but I could be a little bit in the red on general fund. I skipped a slide in there someplace, but you had it. We're servicing about 22% of the Macomb County population in Medicaid. And someplace I had skipped that in my presentation here, but I didn't want to lose sight of that. So the 860,000 people in Macomb County, between Healthy Michigan and Medicaid, 22% are being served, are enrolled and eligible for services, and then should they need services from community mental health, we would provide them. So, the necessity for a risk management strategy, you look at that second bullet there, the department expects that we maintain a risk management reserve that is adequate, necessary, and reasonable whenever possible to cover our risk exposure. So if we have $160 million next year, I have to have monies to cover my risk exposure. And it's kind of getting tricky right now because I've been working with the Macomb House and Senate delegation. I have a meeting with them tomorrow night. And they're all wanting to know, why is it I continue to press for $12.5 million and if I'm just going to put it in the bank? The legislative liaison for the department, I won't say what she did, but she was very unsettled that I needed the $12.5 million to put it in the bank. Well, that's not the case. The fact is that we continue to cut services very aggressively to our consumers. Mm-hmm. To have our financial risk reserve fully funded come this October, I need right around $13 million. I showed you I have $1.5 million. So that $12.5 that we've been asking for the last 18 months still rings true. So what are we doing? We're going to continue to use utilization management practices on our CLS. So you'll probably hear more people that will come before the board, to the Community Mental Health Board in particular. A lot of them are being very vocal, rightfully so. Probably some more that'll be on the TV. We continue to utilize our acute psychiatric inpatient hospital whenever necessary. The urgent care center should be able to defray some of our costs. Our provider network reimbursement rates, I froze those at the 15 rates. They didn't get a rate increase in 16. They aren't getting one in 17. So the board approved the freezing of the provider network rates at the 2015 rate. We actually cut the acute psychiatric hospitals by 5%. We cut them 7% a few years ago, and they continue to take our consumers, and we cut them 5%. We have soft hiring practices going on. The board's not interested in a freeze at this point in time. So it's soft. And in some positions, I needed to replace the CFO. We're going to replace the CFO. Do I need a clerical? No, I may not. So of that workforce of 510 people, I have about 56 vacancies right now. Voluntary furloughs. There's a good number of our staff who have not stepped up. They just don't need the money. They probably work for other reasons in the county, and so we have furlough days that are going on. Macomb Oakland Regional Center is about a $40 million contract. I've renegotiated that contract. I'm taking it to the Community Mental Health Board in June, on June 14th, and it really minimizes the duplication of administrative functions that are going on there, and also gives us a greater ability for aggressive utilization management of the services there as well. CMH board staff travel attendance has been restricted. We continue to be in compliance with all these things that are going on. We continue to be in compliance with our contracts with the state as a PIHP and a CMHSP, and with the integrated care organizations with the My HealthLink demonstration. We will be financially solvent. I can see the light, and it's coming. It's been a hard get, and it's been harder on our families. And there's opportunity for some strategic planning and some reform. That's going to be an interesting time. And right now is an interesting time. I can explain that to you, too. I'll come right back to that in a minute. Been working very aggressively with the Senate and the House delegation on this $12.5 million. They get it. That 17% has never been, that's unprecedented. No community mental health services agency, particularly an agency that services vulnerable people, has ever received that kind of reduction. They understand that it was equivalent to $33 million. They continue to hold the department. A few of them in particular are holding the department in certain that they're working with us not only financially but contractually and technical advice. They haven't given us much technical advice yet, but and that we continue to pursue that $12.5 million. And we would need adequate funding for 18, 19, and 20. Where I talk about where it's going to get interesting in the system reform, we need to attend to our finances and our services in the county. We're not out of this yet. By October, I think I'll be able to give you a whole different picture on this. I think we're going to be able to have survived what we went through, corrected for our financial situation. We may not be whole in our internal services fund, but we're going to be a lot closer to whole than we were a year ago. It's been a deep dive here. I think we'll have adequate funding, or we need to make sure we have adequate funding for 18, 19, and 20. The other things, that's local, and then the other things that are coming out is when the conference committee comes out with their budget, and that's, hopefully they won't go in throughout the summer in the session trying to resolve that. But the state has to figure out their budget for mental health services, substance abuse services, and how they're going to afford those programs. And so we'll wait and see if there's additions or reductions. I know they're dealing with a statewide general fund reduction, how they're going to support those programs. We've talked about Section 298 before. I believe 298 is going to stick, and that the community mental health services programs will be around, and we'll continue to promote those core values, person-centered planning, community inclusion, all of those core values and things that we care about in the county. I also believe that Section 34 is going to be something where they're going to promote pilot programs throughout to be operated by the HMOs, pilot programs. I think that's the harbinger to privatization, and I also believe in my own mind, we'll wait and see, that 234 is going to call for a single PIHP, and that PIHP isn't going to be Macomb County. They're probably going to farm it out to an administrative services organization, an ASO, have an ASO run the whole state of Michigan probably by 2020. So $200 million that we're looking at, we're going to have to worry about that. We're only going to have to worry about that $29 million that's funded to the community mental health services programs. And then on top of that, they're moving pretty slow, because no matter what they put in place, you still have to wait and see what the federal government's going to do. And the federal government comes out with Medicaid block grants, whatever they do with Medicaid eligibility and enrollment, that all gets trumped by the federal's healthcare reform, if that ever does show up and come out. So there's local stuff that's going on, then you got the state issue, and then you got to see what the federal government's going to do. Oops. What we need now, you and I and everybody else, we need to attend to the local demand, awareness to community need. There are so many people out there that have emotional disturbances, serious mental illnesses, conflict in their lives that rise up to our attention. Families with disabled children who need support and needs, and then unless you're close to one, living in one, or spend a day with one, I don't think we really get the full gist of how challenging that can be. And it's not going to go away. And more and more consumers are going to be, I think, stressed and need mental health services due to just the challenges in our environment. More and more substance abuse issues that are going on. We just all need to be really sensitive to what's going on in our community. The state needs to give us adequate funding. And then the Federal Health Care Act needs to have some sensible reform. And we all need mental health.
Yes, sir. Thanks, John. Before we get into some of the questions, is there a motion to receive and file and support? We have a motion by Roulette, support by Myjack. I've got Commissioner Carabelli.
Thank you, Mr. Chairman. A couple of quick questions. Help me out for a minute. You had employees from community mental health, I believe, at the jail for part of their intake and the counseling or for identification, then you cut them. What were the numbers you had and what did you cut?
We had 4 FTEs that were doing mental health jail diversion, and then we cut that back to 1.5, and then the Board of Commissioners gave us $117,000 for funding for 1 FTE, if I have that correct. So we should have 2 people in there, either 1.5 or 2 people doing mental health jail diversion right now.
Okay. Question for the chair of the board, Commissioner Smith. Wasn't it something that was a recommendation from the program from the jail? Wasn't it about we needed to increase the number at the intake for diversion purposes? Did you get a chance, or did anybody give you the report from the jail study?
I do have it. I know it's a lengthy report, and I have not reviewed it, but I do have it, yep.
I respectfully ask that you have either one of your employees or yourself take a look at that, because one of the concerns that they had brought up to the Board of Commissioners is that I know you had done that reduction. They said that they needed more than what you probably had during the time of the original study, that we really need to keep a close eye out on that. The second question I had for you is the 17% reduction, $33 million in 2017. So the other counties all received a 17% reduction of that $33 million?
No, 4 or 5 of the counties actually received a rate increase. Those in the northern and western communities side of the state, as part of the rebase and the redistribution of funds. 2 or 3 of the counties received a 2% reduction.
Okay. Mr. Chairman, the reason I asked you that, I didn't really grasp it when you gave me an explanation of why. And I guess what we're doing in Macomb County compared to the other counties, I don't know if this is a sidebar that maybe you and I can get together and you can explain it to me so I can understand it, but it looks like we're doing something different than they're doing in the other counties, and they're saying we probably shouldn't be doing it, and then they're taking the money away. So again, you tried to explain to me once before here at the board, and I just didn't grasp it. So I guess I'm going to ask offline to get a better understanding of what we're doing differently here than they are in the other counties.
Yeah, sure. Let me know how you want to proceed with that.
Okay. Thank you, Mr. Chairman.
Thank you, Commissioner. Commissioner Toko.
Thank you, Mr. Chair. John, you'd indicated that there was a reduction in services and that you reduced the risk management on the backs of consumers and said you were going to circle back to that. How have you, so all of that has been on the backs of consumers?
Well, no, that was in one of the slides where I also highlighted that we're controlling for acute psychiatric inpatient hospitalization. I had the 56 vacancies, the staff furloughs, the restriction on travel, the reduction of provider rates, the freezing of the rates. So it's not all on the backs of the consumers. Far and away, the way to correct for the budget is on aggressive utilization management, but we have a number of other things that we've done as well.
Do you know like what percentage? I mean, is 60% of it in reduction of services, and what's the percentage of how that pie shakes out?
That's probably around, well, I said we corrected for $10 million, and I would have to believe that, probably $9 million of that is on CLS reduction.
About 9 million of it?
Yeah, probably 90%.
So what does that look like for the consumer? I mean, I know that they had lost, the last time I served on the board, they had lost overnight services.
Right.
What have they lost, what have the consumers lost since then to make up that $9 million?
Well, when we talk about the person-centered planning, if I can just walk you through it real quickly, when they do person-centered planning, we've been engaged in this all along, that the first order of business is they need to apply for home help services through the Department of Health and Human Services. So they may get an hour and a half or 2 hours a day of home help, actually helping them with personal care. And we factor out skill building. Skill building is a vocationally based program for 5.5 hours. We take that out. So now you're at 7.5 hours. You take out the 8 hours from, say, midnight to 8 in the morning when they're sleeping. So now you're at 15.5 hours of services where someone says they typically receive 24 hours of care, those 15 and a half hours have been backed out, and have been backed out all along. And then natural supports, when you start looking at the specificity of medical necessity, just because your child is developmentally disabled doesn't mean that the county has to pay for you and purchase your services for you. That a child parents are expected to give their developmentally disabled or their developmentally disabled or emotionally impaired child the same care as they would give a normal child or one who doesn't have special needs. And so, we may take 4 or 5 hours out of there saying, well, you're asking for community living support services, to help your child go to bed at night. Well, you would help any child go to bed at night and get ready to go to bed. So it only leaves you with maybe 4 or 5 hours for some of those consumers or those families, because there's other supports and services that are there. And then because you have so many different people that you're dealing with, there's some folks that are, as I said before, cognitively able as you and I, with, spastic quadriplegia in a wheelchair and can barely move their thumb, and they live independently because they want to live in an apartment. And so we do provide them with services 24/7. We're asking them to think about a personal response system. So, if you're physically disabled and can't get out of your bed and we're asking you to push a button, you hope that the fire department gets to you before the fire does. And I just have a hard time with that. And I'd say before, if you're having irritable bowel or some type of diarrhea in the middle of the night, I think it's just shameful that we can't be there to help our consumers. Because if I know what I need to do in the middle of the night, if I have diarrhea, I got to get up and relieve myself and take care of myself. And that's what that's the ugliness of the system. You don't want to, support people's wishes to live in an apartment, and you want to take those hours away from midnight to 8 in the morning. Well, that's what we're doing to our consumers. And some walk out the door. They can walk into the street. They can let anybody in their house because they may not have the judgment. And I just think that's not something that's the best humane practice of what our service should be about.
And then, so obviously there are going to need to be further cuts to make up that $13 million this year.
Yep.
And how do you envision doing that?
Continued. See, the plans are coming through on an annual basis, or 6 months or 3 months. So as the plans come up for renewal, then we continue to look at the service. The service is not intended to be, when you look at maintenance of attainment of effort and maintenance of effort. When I interpreted that, and we're still have a review going on by the department. We'll see who's right here. I'm not giving up on that. When it says attainment of skill or maintenance of effort, if I can have a consumer living in their apartment on maintenance of effort and be independent, then that's the decision that we wanted to make. But the department is saying skill building services is not long term. So you gain your skill, and if the goal is to load the dishwasher to make you more independent, when you're done with that skill and you've mastered that skill, I'm not going to teach you, to continue to load the dishwasher or teach you other skills. And so I think you'll continue to see aggressive utilization practice unfold. And so that's how you get to the remainder of the dollars. Now, if I can get the supplemental by the legislation to offset that, I think that there can be a smoothing here. Because right now, if somebody needs to be out of their apartment, I'm not giving 60 days, for an aunt or uncle or mother or father to go find another apartment, for their son or another, provision of care. It's 60, right now. It's no longer medically necessary. There is opportunity to say, well, give me a little bit of time to breathe here, and we'll give you 60 or 90 days to figure out another plan.
So then when these services are cut, and then my understanding is the consumers have an appeal process, correct?
Yep.
So what's going to happen if they win their appeal, and how does that affect the budget?
Well, they win their appeal, and we'll continue to afford to pay for their cost of care. We've had around 130 appeals, and I think we've been upheld in around 120 of them. We've lost about 10 of them.
So are you helping the consumers with their appeals then?
We reach across the table. Sure, there's an administrative law judge, generally from the state, that's on the phone. Sometimes he'll be in presence, in person. Our counsel, Aaron Thomas, with the executive's office, he sits and represents community mental health. The family, usually the sports coordinator, the caseworker is also alongside with them, trying to advocate for services. They may bring in an attorney in. It's not really high legalese kind of stuff, but they have a dialogue with the ALJ for about 60 minutes, and then the ALJ makes a decision. So we do help them, yeah.
And then, thank you. My last question is on the UBHC. Are you realizing the savings that you had anticipated by the establishment of the UBHC?
Our acute inpatient is coming down a little bit. I think we spent around $14 million in acute inpatient, and maybe 13.5, so maybe $500,000 savings on that. If we could attribute it all to
Point of information, I don't know QB, all this stuff, can you guys speak to something like?
Urgent Behavioral Health Care Center. The Urgent Behavioral Health Care Clinic, it was the question that we started over on Garfield. It's the 24/7, 365 program.
John, I don't think maybe a lot of the new commissioners don't know about the center. We had talked about it at Justice and Public Safety a very little bit, but I don't think that they know. I mean, can you explain how the county established that and who's running it? And
We direct operate the program ourselves. We led an RFP a couple times for an urgent behavioral health clinic, and the two times that it came away with a price tag of $6 million. So we said, let's figure out a way to do it ourselves. So that was about 5 years ago. In the last couple of years, we've been trying to get the facility, the staffing, and to be able to get the operations in place. If you're a consumer with severe psychiatric psychosis, or if you have major depression, you don't belong in an emergency room. You just don't need to go to an emergency room. You see doctors and nurses. You need to go see somebody who's a little bit more sensitive to what's going on with your psychiatric dysfunction. So we have clinicians that are in there, so we have psychiatrists in there. We have peer support specialists. Peers are people who have mental illness and have kind of recovered from mental illness. They've walked the walk, and so they can also help and greet and calm the situation. So the environment's much more calming. You want to ever come and visit it, you're welcome to do that. We have the capacity to see 12 adults, 3 children in warming, calming rooms. The intent then is to take someone who's in serious crisis and not, if they're at the emergency room, they're probably going to get admitted. If we can get if we can get eyes on that consumer in an urgent care setting, and if we can find out what's going on, we can offer that de-escalation, that desensitization, be able to have them, maybe identify their caseworker, or we can identify a caseworker. Maybe we can have them go to a walk-in clinic the next day, do a risk assessment, and redirect the consumers out of the acute psychiatric hospitalization. Therefore, maybe it costs $400 or $500 to provide that professional intervention. Comparatively, if they went on to a psych unit, it'd be $6,000 in the course of 10 days. So that's what we're doing. So back to your question, I believe that we probably dropped our acute psych utilization as part of the efforts of the Urgent Behavioral Health Care Center, maybe by about $500,000. There's a slow trending there. Is what the mark was? No, I think our mark was about $3 million. And what the unforeseen piece is that it's costing us a lot in general fund dollars to operate it. So I can only apply so many dollars to Medicaid. If 50% of the people are coming through Medicaid and 50% have commercial insurance or a general fund, I have to account for that accordingly. 50% there and 50% there. So it's an expensive program, and we're continuing to retool it. But there's not much of a margin there, and there's not much of a general fund budget. I'm over budgeted on my GF side. So just the expense and the operation of the program itself is a little bit of a challenge for me right now. But we're fixing it.
thank you.
Thank you, Commissioner. Next, we've got Commissioner Leonetti.
Thank you, Mr. Chair. Couple questions, and forgive me too. A lot of times when you use the acronyms, I don't get them as well. So sometimes just tell me what the acronym is, and then I might understand what you're saying. The first question I had was related to the system reform that you talked about. You talked about Section 234, and you indicated, I think you said the term was AOS. I'm going to assume that's an administrative authority, is what you were saying?
Administrative Service Organization, an ASO, yeah.
ASO, yeah. Am I to understand, okay, and just so I understand a little bit too, okay, Oakland County has an administrative authority that handles their funds, correct? Right. And so does Wayne County?
Yep.
Okay, we don't. We're different in that sense.
Correct.
Okay. Are you saying that this act, this Section 234 thing that's coming down the pike, is this something that's going to eliminate us across the board with all these different Macomb, Oakland, Wayne? It's going to be one central ASO that's going to handle how the funds are going to be dissipated to the counties? Is that what you're saying?
If, when I look at what I hear in the network going on, correct, there was 18 PIHPs that had the administrative responsibility, the managed care organization, MCO, for the Medicaid dollars. That was reduced to 10 a few years ago. And if it comes out that way, based on what the talk on the street is, there would be one PIHP. And I believe that they won't just turn it over to one existing PIHP, and it would be turned over, and they let an RFP for an administrative services organization to be the administrator of that. So all $2.456 billion of behavioral health monies goes to the ASO, and then they would set up common access. Everybody who's getting services the same. They'd set up common CLS, so all the CLS is the same throughout. The billing mechanisms, the claim adjudication would all be the same. The provider network credential and privileging requirements would all be the same. But
now, if something like that happens, like this thing you set up, the urgent care behavioral clinic, that's something that we did on our own, right? You indicated it was something you decided to do as an independent mental health provider. Would we lose the ability to do something like that if Section 234 went into effect? In other words, we're going to be given funds from the central authority in Lansing, let's say, and then we have to decide how to spend those dollars, and assuming that we can afford it, we're going to do an urgent behavioral center, or we're not going to do an urgent behavioral center. Is that correct?
Correct.
Okay.
I believe the ASO would, again, set rates and expect the ASO is, part of tying back to the 298 section of the budget. Mm-hmm. The ASO would be required to contract with all the community mental health services programs, but not exclusively. They'll also contract with Easter Seals and Hope Network and anybody else out there who does the business. And so they may set the rates, and there may be particular services that they want or they don't want. The ASO may say, I really don't like the urgent care concept. Let's do a walk-in clinic. And so they'll be able to predicate what they want from us.
So in other words, we can't tailor it to what we think is best for our community. We're going to be stuck potentially with the standards from the centralized ASO.
Well, I think what we should do, and as I've been talking with some of my board now, we shouldn't do outpatient and a lot of services that we shouldn't do that are common to the network. I think that Macomb County Community Mental Health operates one of the best children's programs there is in the area. We do more children's waiver programs. We have a state model. Best practice standard for delivering children's waiver services to really complex kids, serious emotional disturbance waiver, really complex kids, the autism benefit, complex, infant mental health, complex. I think there's a marketplace in the future for children. Let's treat them when they're young. Let's treat children. I don't think we treat adult outpatients in an outpatient venue. I think crisis services as well, too. I think, any type of crisis-related service where we can go out in the community, urgent care, I think fits that model.
Fits that model.
If they can keep people from higher cost acute inpatient. Yeah.
Mr. Chair, just give me a few more questions. I'm sorry, just a few. I want to go back to the CLS. And again, correct me, I'm learning this stuff as a new commissioner. Is there some conflict between what the state mandates and what the federal mandates in terms of CLS? Like, in other words, and correct me if I'm wrong, the feds want people to be more independent. In other words, they want them to be in their own home. And the state is now saying, look, with this utilization, you should really take a bunch of people and put them into one home, underneath one home, and have one care provider in there. Is that true? Is there that conflict between the federal guidelines and what the state guidelines are?
No, the federal guidelines are becoming more and more inclusive of choice of control, consumer choice of control, than what the state guidelines are at this point in time. And everybody has to move in that direction. And I'm going to sit here. I'm not going to be defensive, but I think that we've got it figured out. I think we're further ahead of the curve relative to the delivery of community mental health services in what the emergent home and community-based services waiver is expecting all the states to do in the coming years. I think we're further ahead. And time will tell.
That's
4 or 5 years now, at some point in time, they're going to say Macomb is off base, or they had it right. I'm convicted that we have it right.
Okay, that's what you were saying when you were saying, I think my argument will stand in a couple of years. That's what you meant by that. Okay. One last question. The $12.5 million that we're short for the reserve, okay? What happens come October if we don't have that? What happens if we're not able to maintain our reserve? What's going to happen? What's the state going to do to us? What's the word up there in Lansing, if you know?
Well, it's that one slide that says I need to have the reserves to assure exposure to my risk. I'm going to continue with my aggressive CLS utilization management practices, and I'm going to find those dollars. I'll continue with my hiring freezes and my rate freezes and all of those types of things. We're moving the needle. Will I be fully funded? Will we be fully funded at $13 million? No. Will we be close enough that we can craft an internal a risk management strategy? It's another thing in our contract, a risk management strategy that'll get us a contract. Yeah, we'll get a contract.
Okay, so to answer my question, if we're close,
Yeah.
we're still going to be able to maintain our independence. Is that what you're telling us? Okay. All right. Thank you, Mr. Chair. I have no further
Thank
questions.
you. Last, I've got Commissioner Smith.
Thank you, Mr. Chair. John, thanks for coming up today.
Sure.
I was up in Mackinac this weekend and had the chance to talk to a few people that were intimate with this situation. It's kind of funny that you mention it because they were saying that a few years ago, Macomb was the one to look at and emulate, and they were doing all the right things. And then all of a sudden, in a blink of an eye, we're the ones that are the problem. Spending too much, and it's amazing how things change in such a short amount of time with the same program that was in place that was so great to many people recently. So I have empathy for your position right now when everything was going and you're building, you're doing the right things for everybody, and then all of a sudden the rug gets pulled out from under you. I have a question. Well, two questions. First, the easy one, I guess. Lobbyists. Are we working with our lobbyists here through Macomb, GCSI, on this, or is that how? Do you have your own lobbyist? How does that work?
I use GCSI, Gary Owen, and it was just recently, just a quick story, I did meet with Nick Lyon, who is the director for the Department of Health and Human Services under Governor Schneider, and also the state Medicaid director, Chris Priest. I had a meeting with them on May 14th relative to our situation, where we're at. Gary Owen was there, Kathy Bartz from the county exec's office was there, and Kathy Vosberg, chairman of the Community Mental Health Board too. And so yes, we are working with the lobbyists there, and Gary gave me some strategy on how we need to continue to move it forward. Nick Lyon said that our request was reasonable. So he would not stand in the way, or when it comes out of conference committee, would he stand in the way or strike our language for a request for $12.5 million. So we seen that as a win, that he said it was reasonable. I said, when do I stop coming up here? If I'm down to 15% reduction, do I stop? When I get to 9% reduction, do I stop coming to you? When do I stop? And it's at 17 right now. So he and Chris Priest, director of Medicaid, who doles out the dollars, they said they would not, the request was reasonable, they would not stand in the way.
Okay. Well, speaking of doling out the dollars, since it's the Board of Commissioners that do a little bit of that too, I'd appreciate it. Maybe a seat at one of those just to listen to what's going on up there in this respect. And so back to Commissioner Toko's question about appeals. I imagine in the past appeals were kind of handled once if they were granted, we had the money to cover them. But in the future, if we're down to the line and a customer, or several of them win an appeal, are we mandated to cover that, or does the state then cover that, or the feds, or is it the same combination and we'll be on the line for it in part?
Well, it depends on the size of the numbers that we're talking about. Obviously, if you're looking at 2,200 people and 4 or 5 of them, 11 of them win their appeal, we'll find that money. We have to find that money to be able to support them. If it becomes the trend in that, that the appellant continues to win the appeal, and I think I have that right, and that the department does not, then we go back to the department and say, look, here's the trend. Here's the shift that, the ALJ is continuing to uphold the consumers because the consumers are right. And then I think we take a narrative and explain why is it that we're seeing more and more consumers that are being upheld by the ALJ, and what does that trend look like? And then it would have to eventually go back to the actuarial analysis when you start looking at all these different factors, comorbidity factors, treatment prevalence factors, all those comorbidity factors that come up into the rate actuarial analysis.
Okay. All right. Well, thank you.
All right, thank you. Any other comments or questions? We have a motion and support. Can you vote, please?
Thank you. Appreciate your support.
Thank you, John.